For those of you that don't know me, my name is Nick Moradi. I'm one of the critical care intensivists here at Florida Hospital Tampa, and I run the ECMO program with Dr. Belisle, who is one of the CT surgeons here. So the talk today is going to be on extracorporeal life support and ECMO. I have no disclosures for this presentation. I don't get paid by any of the companies that make the ECMO circuits or the ECMO machines. I don't get paid as being a part of the ECMO program. I really don't get paid for anything. So, but nevertheless. So why this topic? So I'm going to start off with the talk about ARDS. We'll talk about ECMO towards the end because it's a treatment for ARDS. So ARDS is kind of a hot topic in critical care medicine and pulmonology right now. Over the last 20 years, we've had a lot of advances in ARDS treatment options and our understanding of ARDS. And the last, I'd say 3 to 5 years, there's really been a lot of good evidence to point us in one direction or another in terms of the treatments for ARDS. So I just want to go over all of the treatments past and old, and then we'll get to ECMO towards the end. I was just at the Society of Critical Care Medicine conference in Hawaii, which was tough, just this January. And almost a full day in the main conference room was dedicated to ARDS, different treatment options and things like that. So I'm going to attempt to summarize the main points of that full day in my talk, which should be around 40 to 60 minutes. I'm going to start out with an introduction on ARDS. I want to talk about the epidemiology, the pathophysiology that goes along with ARDS. After that, we'll go through the treatment options, what to do, what is currently recommended to stay away from. We'll then talk about our new ECMO program at Florida Hospital Tampa. And afterwards, we'll have a discussion. So I thought that I would start with a table that I created on ARDS. So this is really simplifying the Berlin criteria. So the Berlin criteria came out, I believe, in 2012. And that's really the accepted standard for diagnosis of ARDS. That replaced the 1998 standard for definition that was put out by the American European Society consensus statements on respiratory distress, which back then was called shock lung. And you'll hear a lot of people still calling it shock lung, but I think that most of us new guys, like myself, refer to it as ARDS. So timing-wise, it should be acute onset within 1 week of clinical insults, such as an upper respiratory tract infection, influenza, something like that, or new or worsening respiratory symptoms, which is really an incredibly broad term that means anything, so it really could happen at any time. I'll come back to the P to F ratio. Your PEEP requirement for mild or moderate should be at least 5, and for severe should be 10 or more. The origin of the edema should be respiratory failure, not completely due to cardiac failure. That's a slight change from the definition before. Before we used to say, well, if you have heart failure, you can't really call it ARDS because maybe the heart failure is causing fluid to back up into the lungs. We give a little leeway now. And for my own personal practice, I really treat severe hypoxemic respiratory failure the same, whether it's from pulmonary edema, from a cardiac issue, or whether it's straightforward ARDS. Either way, they're severely hypoxic. It's refractory to standard treatments. We should be aggressive in trying different therapies. Radiologically on the chest x-ray, for mild or moderate, you should at least have infiltrates or opacities bilaterally. And for severe ARDS, the opacity should involve at least 3 quadrants when looking at lung fields. Now let's get back to the P to F ratio for a second. So your PaO2 and your FiO2, if you take that ratio, if that ratio is less than 300, that's diagnostic for ARDS, given that you fit all of these other criteria. If it's between 200 and 300, that's mild. Between 100 and 200, moderate. And less than 100, we call severe. Now, that being said, pretty much all studies that are big studies, landmark studies, such as ProSiva for proning, the paralytic trials, all of these trials use a cutoff of 150, and they call it severe ARDS. So you're probably wondering, well, the Berlin criteria says less than 100. They said severe is less than 100. Why are all these other studies calling less than 150? Well, they want to get more people into their study. They want a higher power. So they use a little bit of a higher cutoff to have a bigger basket to grab people. We use the same thing here for our hypoxemic referral center, and I'll get to that later on. But that's the reasoning behind why. So let's look at the incidence of ARDS. So approximately 64 in every 100,000 people in the United States will suffer from this. So that's a 2014 number. The last time that was looked at was 2008, when it was 39 out of 100,000. So you might wonder, well, why are more people getting ARDS? Any ideas? You guys just started eating, so. Sicker patients? Maybe. And patients do survive longer to make it to us and to make it to tertiary care centers or to make it to diagnosis. So that's a good thought. But really, I think that it's a historically underrepresented number, and that's kind of what the consensus is. Keep in mind that that number of 39 was from 2008, before we even had Berlin criteria. Also, I don't think that we look at refractory hypoxic failure the same way now that we did 10 years ago. And I think that ARDS is becoming more common, and it's becoming more appreciated. We're able to diagnose it earlier and therefore intervene earlier, and I think that's important. It affects 10 to 15% of all ICU patients, and it affects 20% of all mechanically ventilated patients. There are about 200,000 cases per year in the United States alone. The incidence increases with age, smoking, alcohol history, and critical illness. Just to give you an idea of how much your risk of ARDS increases with age, the incidence in the less than 19 years old is 16 per 100,000. That skyrockets to 306 per 100,000 for your aged population, 75 to 84. So it wouldn't be a great presentation unless I had some slides that otherwise we would never see. This is beautiful normal lung. So you see right here, this is your open alveoli, and these things here are your basement membrane. If you can picture capillary beds coming at you. So this is almost a cross-section of the capillary beds coming at you. This is a type 1 alveolar cell, type 2 alveolar cell, which is responsible for surfactant production. That's not really that important for ARDS, but since the arrows were there, I thought I'd tell you what they were. Now, you can see with these wide open airways and this nice thin membrane, the way that your lungs work is once the air gets into these alveoli, oxygen diffuses across the membrane into your capillaries, and CO2 diffuses the opposite direction back through the capillaries into the alveoli so that you can breathe out CO2, breathe in oxygen, and there's good diffusion there. So this is mild to moderate ARDS, early onset. You notice that the basement membrane is very thickened. This is an eosinophilic hyaline membrane, kind of thick, so oxygen and CO2 cannot diffuse across that, and it's difficult for it to really diffuse across a thickened membrane like this. So that's why you start to get a little hypoxic, you start to ventilate a little bit more poorly. So what do you guys think of this slide? Pretty horrible, right? So this is severe ARDS. Now you can see why you have patients on all this oxygen support with mechanical ventilation, with non-invasive positive pressure ventilation, vapotherm, and their O2 sats are horrible. Well, no matter what you do, it's not going to get through this membrane. This is all that same eosinophilic hyaline membrane diffuse. There's no diffusion across there. Your membranes are significantly thickened. Your lungs just don't work anymore, and this is why. So let's talk a little bit about the pathophysiology behind it. So you do get decreased gas exchange because there's a VQ mismatch. As I just kind of explained, when you look at this severe ARDS slide, I think it's easy to see why they're shunting, because the blood is still flowing through these capillaries. But when you've lost your basement membranes and lost your diffusion, it's impossible for you to have that air, that oxygen and oxygenation and ventilation across that. The alveolar septum are thickened from fibrosis. You also get decreased lung compliance because your lungs get stiff. So they don't open and close the way that they should be. You also alter the pressure volume characteristics of the residual lung units, which means in addition to all the bad lung units that aren't working anymore because the membranes are thickened, the good lung units also don't work as well because now they're getting barotrauma and volutrauma because you're giving more volume and more pressure to the lungs as a whole. It's trying to get the bad lung units to work, but it's also damaging the good lung units because the good lung units don't like all that pressure. You also get increased pulmonary artery pressure. So pulmonary hypertension occurs in up to 25% of patients with ARDS. And the causes for that are hypoxic vasoconstriction, vascular compression by positive airway pressure, parenchymal destruction, and airway collapse. Here are treatments that are currently in favor and should be considered for use. I'll go through each one of these in detail, but in short, you can set your FiO2 by your PEEP by a little chart that I'll show you. You can calculate a compliance curve for optimizing PEEP. You can do recruitment maneuver, inverse ratio ventilation, paralytics, proning, and extracorporeal life support. Treatments to avoid. These are treatments that have been tried in the past, probably used for a while. I'm sure probably some of the pulmonologists here have had some experience with this. It's probably been varying. So I'm just going to go over what the most current, pendulum swings in all of medicine. I'm just going to go over which side the pendulum is on for these, which is to avoid them and why. So the OSCAR trial came out in 2013, a very good trial for high-frequency oscillation in severe ARDS. The trial showed no benefit. Because there was no benefit, and this was in, I believe it tested 795 patients, pretty good study. As you can see in the curve here, there was absolutely no benefit from it. And if you've ever seen it in use or used it, it's not the most pleasant sight. So the current recommendation is to avoid high-frequency oscillation for this. Intravenous prostaglandins. So these are vasodilators. So these were studied pretty extensively as well. They have been shown to decrease your blood pressure and not improve oxygenation at all. Inhaled nitric oxide. So if anybody has any experience with that, it's great. You put a patient on the nitric oxide, you see the SATs come up. Does that mean anything? Not really. So it didn't lead to any benefit other than increased oxygen saturation. It is recommended that you avoid them. And my personal experience, and I'd like to ask some of the pulmonologists in the audience if it's their experience as well, when you put a patient on nitric oxide, the SATs come up and you feel great about yourself, and then the next day, 2 days, 3 days, you try to come off nitric oxide and it just doesn't happen. So now let's get into treatments that are in favor. So this was published with the ARDS and ECMO guidelines. So really what you do is, all of that showed that higher PEEP, lower FiO2 is where you get your benefit. So you see what PEEP the patient requires and you match up the FiO2. So what one of my predecessors here at Florida Hospital Tampa did was he made copies of these cards for all the respiratory therapists so that they could treat hypoxic patients in a standardized fashion. So this is a good thing because it's easy to use. You can pass out cards, everybody can be on the same page, and it doesn't require a lot of calculations or trying different things. I actually don't use this method, but there are the pros that I just talked about for why to use this method. Compliance curve, I actually use this a great deal. So if you imagine your lungs don't, the lung units, the alveoli in your lungs, don't all get affected in the same way, to the same degree, at the same time in ARDS. It's constantly changing. Some people's lungs are getting better, their compliance is improving, some are getting worse. Different areas in the lungs are getting better or worse at any given hour throughout the day. So the reason I like to use this is I think it takes into account that particular patient, and it takes into account how bad the disease is at that specific moment, which I think is probably the best way to optimize your PEEP. So what you do is you measure the compliance of the lung at different PEEPs while maintaining the same tidal volume. So most of us in this room know, okay, ARDS, hypoxia, all patients, 6 cc's per kilogram ideal body weight. As an aside, I try not to use higher than 6 cc's per kilogram ideal body weight for any mechanically ventilated patient. So the way to calculate it is you take your tidal volume in liters, which is going to be a constant because you're not going to change it. You check your plateau pressure. What I do is I do an inspiratory hold. I do 3 times at each PEEP. So if the patient's hypoxic, you're usually on a PEEP of at least 8, 10, 12, something along these lines. So what you do is do an inspiratory hold and see what your plateau pressure. I do it 3 times for each PEEP, just to make sure I get a good average and one number doesn't throw me off. And then I'll check it at different PEEPs, usually going up by an interval of 2. So let's say I started with a PEEP of 8, and I want to see, okay, it's 7 a.m., I just started my day, where do I want this patient's PEEP to be right now? I'll check the compliance at a PEEP of 5, 8, 10, 12, 14. Wherever the best compliance is, theoretically, that's where your best oxygenation should be. So wherever compliance is best, I choose that PEEP, and that's what I set the PEEP at. How often do you want to do this throughout the day? I like to do it twice a day. If you have students, residents, fellows, respiratory therapists, respiratory therapy students, you can do this throughout the day, 4 times a day, even sometimes 6 times a day. And it does change because people's compliance are constantly changing with their disease getting worse, better. So that's why I like to use this. I also do a lot of recruitment. So before I came here in fellowship, one of my mentors is well known around the world for sepsis because he's leading the Surviving Sepsis campaign, long history of sepsis, but he also talks a lot about ARDS. So he almost completely uses recruitment, and he really doesn't use any of the other maneuvers. So the way that this works is you give the patient a PEEP of 30 for 30 seconds or 40 for 40 seconds. And then once you come back down to a higher PEEP than you started. The reasoning is this will pop the alveoli open so you can recruit more of them. And when you come back down, you want to come back down to a higher PEEP because you want to maintain all the recruitment that you just did. So let's say they have a PEEP of 10 and you know the other vent settings don't change. You tell the ventilator, I just want to give a PEEP of 40 for 40 seconds. You time them. After the 40 seconds, since we started at 10, let's come back down to 12. Once you do that, you want to give it about 5, 10, 15 minutes to see what the effects are. Sometimes the effects are immediate and go away. Sometimes the effects are immediate and they stay and everything works great. Sometimes you don't see the effects for 5 or 10 minutes, then the oxygen saturations rise up. Now let's say you try this and it doesn't work. Then what do? You can recruit again. You can keep recruiting and coming back to a higher PEEP until your plateau pressure is 30 or more. The downsides to this, decreased blood pressure. So this is a significant issue, and most of the patients that are this critically ill in severe ARDS are on vasopressors. So what I like to do is I go up on my vasopressors before doing a recruitment maneuver to give me a little extra buffer zone so that when my blood pressure drops, which is usually less than 5 millimeters of mercury, that I already have my buffer zone, so I don't have to abort it early. And you can abort it early. If your patient's blood pressures start to tank or they have some very significant arrhythmia, just abort the test and go back down to where you were. If the patient has a pneumothorax, try to avoid doing this because that could increase the chances of bronchopleural fistulas. So, ventilation mode. So I won't go into all the different vent modes and all the different things that you can try. There's just a couple things I wanted to touch on in terms of ventilation modes. Sometimes something as simple as switching from a volume control mode to a pressure control mode can improve oxygenation. The reason for that is when we set volume control mode of ventilation, we're setting the flow for the patient. If they're awake or semi-awake and breathing with the ventilator, then they could have ventilator dysynchrony. Patients like pressure control more because they have more control over their flows in pressure control mode. The other thing that I really wanted to touch on was this is inverse ratio ventilation. There were a couple of important points I thought I really need to touch on. Looking at this waveform, those of us that are familiar with inverse ratio, this is the pressure and time high, and this is the dump time, the pressure or time low. So the 2 points that I think are important to hit are, it took me getting out of residency, getting past, I did a year as hospitalist, and getting back to fellowship until I really understood inverse ratio and understood how I was doing it wrong. So the reason that you can't have a patient paralyzed on inverse ratio ventilation is they need to be breathing and ventilating at the time and pressure high. When we think about ventilators, we think about, okay, it gives a breath, that's your inspiratory time, and then it lets you exhale, expiratory time. Inverse ratio doesn't work like that. You have to be ventilating at your time high. The dump time is just a little bit of extra time to get a little kick of extra ventilation. Otherwise, you'd be in bad shape in terms of ventilation and respiratory acidosis. The other thing that's important is your pressure low really should be more than a standard PEEP of 5, or sometimes people set the PEEP to 0. Yes, that might improve ventilation a touch, but remember the whole thought process with hypoxia is popping those alveoli open with recruitment and keeping them open. If your PEEP is that low, you're defeating the whole purpose of keeping them on such a high pressure for so long. So I recommend keeping the PEEP at least 10 or higher so that you don't lose your recruitment. So treatments, bicarb. So I've noticed since being in practice and out of all of my trainings, whether as a hospitalist or intensivist, that we use bicarb for a lot of things in the real world. This is actually an indication for bicarb use. If you have severe ARDS, we consider it acceptable to have permissive hypercapnia to a pH of 7.20 and above. That's the trade-off to try to prevent too much barotrauma and volutrauma. Barotrauma and volutrauma are phrases that respectively mean damage from too much pressure to the lungs, which means you go up on the pressure in the ventilator, you're damaging the lung because that pressure hurts your alveoli. And volutrauma, too much volume can hurt the lungs. So we say 7.20 up and 7.20 and higher is acceptable. If you're between 7.15 and 7.20, a lot of people agree that it's reasonable to start a bicarb infusion to synthetically keep your pH 7.20 and above. Now let's say your pH is 7.15 and below. Then what do? You have to do something else. You have to ventilate, you have to prone, maybe ECMO. You have to do something else because whatever you're doing isn't working. Paralytic therapy. So there was a very good trial in the New England Journal in 2010 that showed that if you paralyze patients for the first 48 hours after diagnosis of ARDS, that you have a significantly improved mortality. Both 28-day mortality and 90-day mortality decreases by about 15% without the critical illness, neuropathy, and muscular dystrophy that is associated with paralytics. The reason that I put cisatracurium is because this study, they only used cisatracurium, which is, the trade name is Nimbex. Can anybody think of why they didn't get critical illness neuropathy with Nimbex as opposed to other drugs? No? Okay, then I'm glad that I put it on the slide to talk about it. So Nimbex is the only paralytic that undergoes something called the Hoffman degradation. Almost every other medication that we give to patients has to get metabolized and has to get excreted. So to some percentage it has to go through the liver and then it has to go through the kidneys for us to excrete it. Cisatracurium does not. The Hoffman degradation, it spontaneously degrades and resolves in your blood, which is why I think you don't get the critical illness neuropathy with it. So this study showed the benefit without the muscular weakness that you get with other paralytics. So the big question is, well, this was before ECMO became so favorable. If a patient's on ECMO and you're using extremely low volume ventilation, do you even need it? We don't know. We still use it here for 48 hours because that also helps us get everything to calm down, get the patient on the ECMO circuit. Everything's just a little bit more relaxed with the patient paralyzed for the first 2 days. Do we absolutely need it? Maybe, maybe not. We don't know. There aren't any good studies to let us know, and different big name centers do different things. Now, proning. Some of the possible adverse effects are retinal hemorrhages, blindness, that happens in less than 1%, and pressure ulcers, a little bit more common depending on the method that you use for proning. This is the ProSiva study. What they did was they prone patients for 17 hours plus or minus 3 per day. Then they would unprone them, give them their routine care for the day, chest x-ray, wash them, whatever you need to do, and then reprone. Now, there has not been a follow-up study to this. This was in 2013. But I can tell you, I go to all of the SCCM conferences. I've been to CHEST. The big centers that do a ton of proning, that are kind of leading the way in proning, and the people that head those centers that give the talks, I've talked to them afterwards. Every one of them is in agreement that even though the literature says 17 hours and flip them once a day back, everybody is in agreement, keep them proned until they're getting better. So that's what we do as well. Let me just show you a patient that I had proned. So this is a patient that I proned in the bed. You can either prone in a regular bed, or you can use some mechanical beds that I have some slides that I'll show you in a minute. So this is a patient that had ARDS, severe failure, doing horribly. I came in and in the CCU at the bedside, walked the nurses through proning the patient. As you can imagine, everybody was on edge and tense. Why would we prone in the bed? We have to get a mechanical bed. Well, what I learned is there's a very steep learning curve with proning at the bedside. I walked them through it once, twice. By the third time, the same nurses that were on board after the third time, they were teaching all the other nurses how to do it. They felt comfortable with it. They actually liked it much more than the mechanical bed once there was a little bit of familiarity. So a couple of points for proning. You'll notice that the leads are taken off the front and put on the back of the patient. I also put pads on patients before we prone because let's say they should have an arrhythmia or something like that. We should be able to shock it immediately without having to unprone the patient first. It only takes maybe 30 seconds or so to unprone a patient if they do have an arrest. And I put all the lines that are possible in the patient before proning because I don't want to have to worry about that after the fact. You can put in IJ lines, and I haven't tried femorals, but maybe femorals with the patient prone, maybe not. But I just line them up beforehand with triple lumen. If there's any chance that they're going to need dialysis, if there's any renal failure, I throw in a dialysis catheter. One of the methods that I've used that I've had great success with in terms of preventing any kind of pressure ulcers is, you'll notice I have a bunch of blankets folded under the bed. So I believe in low-cost interventions. Almost any hospital you go to, you'll have blankets. So by folding these blankets and putting them across the patient's chest, you're distributing the pressure of the patient's weight across the whole chest. And that chest wall can actually take a lot. I also elevate the chest because, as you can imagine, when somebody's prone, they're hyperextended. As you elevate the chest, it kind of brings the neck down, and it also decreases the pressure on the patient's face. So the patient's face is just lightly touching the pad in front of it instead of being hyperextended and having the weight of the patient's head on there by lifting the chest. It also works in patients with a large abdominal girth by decreasing the pressure on the patient's abdomen. It's been my experience that the chest wall can handle the pressure, especially when distributed across, much better than your face, abdomen, anything like that. And I have proned pregnant patients across 2 beds before with her belly in the middle. It can be done. There are multiple different face masks that you can use when proning. This is probably the cheapest option. It's a big piece of foam. The pro to using this is, you can see I used a little permanent marker. I cut out exactly where I wanted the tubing and things like that to go. This is the patient afterwards. He was proned for about 3 or 4 days. So this was about 4 months later, not even, I think 3 or 4 months later. As you can see, he was about 50, 60 pounds heavier when he was in ARDS, when he had been in shock, when he got resuscitated. He did gray his hair out from the ordeal, but this is actually the same patient. I almost don't want to put these slides up because this patient looks so much different than when he did before, but I have plenty of nurse staffing that can assure you this is the same patient. Here are just some pictures of the mechanical proning beds. Okay, so now let's get to the sexy treatments, ECMO. So let's talk about the terms first. So ECMO is nice and easy to say, so I've been using the term for this presentation. It stands for extracorporeal membrane oxygenation, which basically means, just like dialysis, you pull blood out of the patient, oxygenate it, and put it back. But you can actually use extracorporeal life support for lung bypass or lung and heart bypass. So ECMO really, as a term, only encompasses lung bypass. But extracorporeal life support encompasses both, whether you're doing heart-lung bypass or just lung bypass. So it's a more appropriate term, and in terms of our program here, we call it an extracorporeal life support program. The two main parts of the whole ECMO circuit is the oxygenator, which, just like the phrase, it oxygenates the blood, and the centrifugal pump, which pumps the blood from the patient to the machine and then back to the patient. There are 3 types. I just talked a little bit. Veno-venous is lung bypass. Veno-arterial is heart and lung bypass. And venopulmonary artery we don't do here, and it's done at specialized centers, so I won't really go into that. So when do you want to do ECMO? The sooner the better. So I gave you those list of treatment options. To have your maximum mortality benefit from ECMO, you should try everything else, have it fail, try something different, see that everything else has failed, and get the patient cannulated and put on ECMO within 6 hours. You can imagine how difficult that is. It's similar to antibiotics and fluids and sepsis, the golden hour to try to get everything in. That being said, the earlier the better. Realizing we can't get every patient on ECMO within 6 hours, that doesn't mean at hour number 7 we say, we missed our window, forget about it. The sooner the better still. Even if you're a day, 2 days out, the sooner the better. Who runs ECMO? So Extracorporeal Life Support Organization, ELSO, is the national accrediting body in the United States, and they actually do work worldwide. They get their information, a lot of it, from the Alfred ICU in Melbourne, Australia. They've been leading the way for all ECMO and ECMO research, probably for the last, I'd say, 5 years. And they created something called the RSP score, which for veno-venous ECMO, that gives us an idea, okay, if you put this patient on ECMO right now, what's the mortality going to be? What's the survivability? This Alfred ICU in Australia they're probably the leaders in ECMO everywhere, so that's where we've modeled our guidelines and protocols that we do here to try to keep up with them. The bigger centers in America over the last 2 or 3 years have been doing the same. So to do that RESP score to determine mortality, you go to this website, respscore.com. Again, nobody pays me for anything, but this is put on by ELSO, by the Extracorporeal Life Support Organization. And you fill in the patient variables on the right, age, what kind of respiratory diagnosis did they have, neuromuscular blockade, did they arrest, and this is what you get. So I just filled in a couple of variables. The score would be -5. This tells you estimated survival. So this patient's estimated survival is somewhere around 10 to 30%. Not too high. Might not be a good candidate for ECMO. Here's a picture of these huge catheters that we put in so that we can get patients on the ECMO circuit. You'll notice they have multiple fenestrations to maximize blood flow. So do you guys think that this is a venous line or an arterial line? What's your guess?
Arterial.
Arterial, excellent. Absolutely right, it is arterial. Why? Why?
Bright red.
Excellent. I was hoping you'd say that. Totally wrong. So that was a setup question, but thank you.
You always do that.
So why was that a setup question? What does the ECMO circuit does? It takes blood from the venous side and it oxygenates it. Doesn't matter if it's veno-venous or veno-arterial. It takes blood, oxygenates it, and puts it back in the body. Doesn't matter if it goes back to a vein or an artery. Either way, it's coming back bright red because it's oxygenated before it goes back. But the reason that we know that this is arterial is we've learned over time that if you put this huge catheter in somebody's femoral artery, it blocks off the flow distal to the insertion site. So this leg distal going down to his feet would become blue and fall off. That's why you have this distal perfusion catheter that supplies arterial blood down, that oxygenated blood down the distal femoral as well. This is the cardio help machine. It's the most advanced machine in the US market today. Tons of bells and whistles, looks very pretty, and it's very compact, so it's optimal for transport. It's also by far the most expensive. This is what the back of it looks like. This is where you plug things in, all the sensors. These are the magnets for the motor that link with magnets in the back of the oxygenator because that's built into one for the cardio help machine. So this is the Quadrox D oxygenator. This is really where a lot of the magic happens. ECMO is becoming much more commonplace and working much better because the machine is better, and mostly because the circuits and this oxygenator are better. The magic is propyl methyl pentane, which is what coats these for your gas exchange. They really don't clot almost at all. We've had a patient that's on ECMO right now that's been on for 12 days, I believe, off heparin completely, and he has not clotted at all. That's incredible. They also have a much longer half-life. So the standard oxygenator, the listed half-life is about 6 hours. This is 2 weeks, and I've had patients go up to 6 weeks without needing to do a circuit change and change the oxygenator. So just so you guys know what's going on in this magical membrane, it's a countercurrent exchange, very similar to how hemodialysis works. The water that's running this way is really just to heat or cool the blood, so you can adjust the patient's temperature. So this is fresh gas flow, and this is the patient's blood flow. So as the patient's blood flow is coming across, it's exposed to this membrane that separates that and the fresh gas flow. So the fresh gas flow is bringing the oxygen. The oxygen diffuses across its gradient because the PO2 of the patient's blood is, let's say, 50. The fresh gas flow's oxygen level is hundreds. So it diffuses across that gradient into the blood, and vice versa for the CO2. There's no CO2 in the fresh gas flow, so the CO2 from the patient's blood diffuses the opposite way into the fresh gas flow. That's also important because let's say a patient's CO2 is too high and they're on ECMO. What do? We increase the fresh gas flow because the faster you can move out CO2 molecules through that fresh gas flow tubing, the more of a diffusion gradient over time you have for the CO2 to leave the blood and enter the fresh gas flow to rid more of it. The opposite really is true for oxygenation, whereas to improve the patient's oxygenation, you want to increase the blood flow so that over time you have more surface area of the blood flow interacting with the membrane for the fresh gas flow to get all the oxygen in that tubing to diffuse into the blood. Here's a side view. Blood goes in through the pump and shoots out through the oxygenator. This is the catheter that I was speaking of. This is called the Avalon catheter. It can only be used for veno-venous applications. So this goes into the IJ. It has outflow ports in the SVC proximally and in the IVC distally. So that's where the outflow pulls the blood out of the patient and goes down here, the dark blood. Then after it gets oxygenated and comes back, there's one little side port, not really little, but there's one side port that you put right at the cavo-atrial junction, and you angle it so that it shoots into the right atrium, and you angle it directly at the tricuspid valve. So to put this in, not only do you need fluoroscopy, but you also need transesophageal echo because you need to see the flow when you're angling it to make sure it's just right. And they are a breeze to put in. So they can be extremely complex to put in. The wires have a tendency of folding and going into the right atrium, getting it to angle just right. Can be difficult, but once they're in, it's much I think that it's much better than having the patient have 2 cannulas. Also, we'll get to it later, but it's possible to extubate the patient before putting them on before decannulating them so that they can ambulate while on ECMO, and so that if they fail again, you can just go up on the ECMO settings. But that's way in the future for us. So, ECMO settings. If they're hypoxic, I already talked about why you would increase the blood flow. If they're hypercapnic, you increase the fresh gas flow, which is also known as sweep. If you have both, always address the oxygenation first, and then the CO2 later. And the FiO2 on the ECMO circuit should be 100% at all times. Ventilator settings. ECMO does not treat ARDS. Technically. What it does is it bypasses your lungs to give them time to heal from ARDS on their own. So the whole point of it is to let the lungs rest. So that's what we do. So 2 to 4 cc's per kilogram ideal body weight is what's recommended. We use 3 just because I like single numbers and standardization, so that's what we chose. A PEEP of 10 to 15, we use 10. FiO2 of 35 to 50%, and a rate of 6 to 10. That being said, some patients don't breathe at all on veno-venous ECMO. There are transplant patients that are on ECMO for a long period of time. Their lungs are in horrible shape, and they just don't breathe. And it's very strange at first, but they don't breathe because they don't need to. The ECMO is doing the work. Once the patient's no longer paralyzed, we switch to pressure control. The reason for that is you match your peak inspiratory pressure with what 3 cc's per kilogram ideal body weight was. That way the patient can control their own flows a little bit better, so they're more synchronous with the ventilator. But also over time, as the compliance improves over the next day, few days or weeks, you'll see the tidal volumes increase without increasing pressures. And then you can go down on the inspiratory pressure. So that's why we like pressure control. Anticoagulation, also a hot topic. Everybody's pretty much in agreement with a bolus of 50 to 100 units per kilogram when you initially start. That ends up being between 5,000 and 10,000 units. To measure your anticoagulation, what should we follow? Anti-10A is the best, ACT is in second place, and the bronze medal goes to PTT. A lot of different factors affect PTT, so it's really not the greatest. We go by ACT here, and we recently got anti-10A levels. We're going to consider switching. We do have a protocol so that we can go by anti-10A levels, but ACT for the short term seems simpler, more efficient, and easier for us to follow. So we're going to stick with that for the short term at least. Our goal is 150 to 180 seconds, whereas ELSO recommends 180 to 220 seconds. That recommendation is 2010. They haven't updated it, but there's a lot of evidence, specifically a University of Maryland 3-year study that was presented just this January. They did even less than 160, and not only did they have less bleeding, they also had less clots, which is counterintuitive, but it just goes to show how good the circuits are now. And like I said, we've had a patient on for 10 days with no anticoagulation and no clots. So when it's time to wean off of ECMO, wean the sweep, you can wean blood flow. If you wean blood flow too low, that increases your risk of forming clots. So we recommend not going less than 2.5 liters per minute. Once your sweep is weaned all the way down to 0, you're essentially off of ECMO. Once your sweep is 0 for 4 to 24 hours, that means it's pretty much safe to come off of ECMO, which means decannulation. The next step is controversial. Which one do you do first? If you have that Avalon catheter in your neck, do you decannulate first or do you extubate first? So my surgical colleague is going to pick the side that, well, you should always decannulate first because you don't want a patient awake with these big cannulas in. They can pull them out, they can go crazy, they can do whatever. Very true. My counter argument would be, well, when you have a patient that's been intubated, sedated for a month, a few weeks, longer on ECMO, their lung muscles are very weak. The diaphragm is weak, the intercostals are weak. So when you eventually extubate them and you're going from positive pressure ventilation back to negative pressure ventilation, some of them struggle with that. Now what happens if they fail? Well, they have to get reintubated, you have to go back up on the PEEP, and you start the whole process over again. Now let's say you have that same patient, only this time he still has his Avalon catheter in, so he still has the ECMO machine even though we're not using it because the sweep is at 0. So you extubate him and he goes into distress because his muscles aren't working, I can't get the volumes he needs. Well, he's on ECMO, you don't have to reintubate him. You just go back up on the ECMO. So there are pros and cons to each. So those are treatments. So now quickly I'm going to talk about the 2 new programs we've started at Florida Hospital Tampa. So we have 2 programs. One is an ECMO program that we have been doing for a while, but we formalized just recently. And the second is a referral center for refractory hypoxia that will feed into the ECMO program when appropriate. So like I said, we've been doing ECMO for about 2.5 years. I've been here for about 8 months, and for that 2 years approximately, Dr. Belisle, CT surgery, was doing it before me. We have put a total of 11 patients on ECMO. 2 patients are still on right now, so I can't tell you the numbers for that. Technically there are 3, and I see the fingers in the back of the room, and I'll go over why I said 2 in a second. So we have an 8 out of 9 survival, so 89% survival rate for veno-venous ECMO here at Florida Hospital Tampa. That's an awesome number to have. The national average was about 40%, all the way up until 2015. In 2016, it sounds like we're doing things better because the national average is up to 55%. That being said, we're way ahead of that average, doing 89%. And you might say, well, how many cases do you need a year to be a center of excellence and to be really doing it right? ELSO says 6. And we've done 6 in the last month. So we're doing it. We had 1 death. This occurred when we broke our own rules. So when we decided to formalize the program, we all got together. We decided a BMI cutoff of 35. The reason for the BMI cutoff was that when you put a patient on veno-venous ECMO for severe ARDS, sometimes your lungs go into that fibrotic stage of ARDS and they don't come back. So your lungs become rocks. If you're on ECMO for 3 months and your lungs become rocks and aren't going to come back, you have to be a transplant candidate. Otherwise, you just went through all of that for nothing. Resource allocation, procedures with patients, they're bound to have infections that come and go. There's a lot that goes into it. If you're not a lung transplant candidate at the end, it's a bridge to nowhere. Most people would agree that's probably not the best way to go. So most lung transplant centers have a BMI cutoff somewhere between 28 and 32. We chose the higher of all of them at 35 to try to include all the patients that we can. The 1 death that occurred had a BMI of 62. She was way up there. But that being said, the reason that she was put on is she was 30-something years old, and I'm sure all of you in this room know Dr. Blau, and he has a huge heart, and we wanted to give her every chance we could. So we did. Now, the reason that I said 2 are pending is before I came, we had, I believe, 5 of these cases were done before I came, 5 veno-venous. Either 4 or 5 veno-venous cases before I came. Since we sat down, formalized the program, 3 weeks ago we had 2 people on ECMO at a time. Last week we had 3 people on ECMO simultaneously. We decannulated one of them who is on a couple of liters nasal cannula and leaving us to go to rehab today. This week we have 3 on again as of this morning. One of them has their sweep at 0, and it's been on 0 for well over 4 hours. We're just waiting for our surgical colleague to pull out the tube. So I count that one as a win. So I'm going to include that as 8/9. That's why I'm saying we only have 2 pending when technically we have 3 on the circuit. It's just working as a shunt and it's not really doing anything. So I count that as a win already. Let's see. So let me talk about our referral center. So we're accepting patients with refractory hypoxia. As I stated before, we're going to use a P to F ratio cutoff of 150 because we want to get more patients, not just because we want more numbers and volume, but everybody's in agreement that the earlier you intervene with any treatment, the better. We want to get the patients earlier because that's what's going to save their lives. We have our transfer center open 24/7. We have intensivists in-house 24/7. And we've created screening sheets for MDs, nurses, and respiratory therapists. Here's what they look like. So if you notice, we had the inclusion criteria almost mimic that chart that I had for ARDS. We have some exclusion criteria here. We have some absolute exclusion criteria and relative exclusion criteria. We also made little cards that I think we now have. And for all of you that want, I believe we have some copies of the screening sheets and cards in the back. Inclusion criteria is what's on there. P to F ratio of less than 150, PEEP of at least 5, multilobar infiltrates, and it's not all heart failure. Absolute exclusion criteria, cardiac arrest, BMI, high BMI, non-severe ARDS. Now I included cardiac arrest even though we do veno-arterial ECMO in patients that are actively arresting, and ECMO is often done in patient status post-cardiac arrest. But I do think it's important that when you're building a program, you want to create it to support the patients that could benefit most from it because it's an incredibly high resource allocation for ECMO. So especially when you're just beginning, I think that it's important that you utilize the resources in the most efficient way possible because if we put a lot of patients that had cardiac arrest and anoxic brain injury on ECMO and then our ECMO program gets taken away from us, there's a lot of patients that we might have been able to save that we didn't. So at least for now, that's where we're starting. Relative exclusion criteria, age over 70, multi-organ dysfunction, a BMI, kind of that borderline of high range. This is a data collection sheet that we created so that when the CV coordinator or the ECMO coordinator calls us with a proposed case, we have all the information that we're going to ask for and they will have it ready to go. And really that's it. I do want to say that it is a growing program. We had 3 people on last week. We were down to 2. I came in early this morning to help out the ICU because we had a new locums guy working last night. And I came at 5 a.m. and the patient that was just intubated 30 minutes earlier needed ECMO. Thanks to calling Dr. Bilal and him coming in emergently, we now have another case on ECMO that was just an hour ago or 2 hours ago. So I think that it's going as well as can be expected. I will also say that I've had tremendous support from all the services because when we first started our new protocolized, standardized approach, it required meetings about 3 times a day that I met with our unit director, Carrie, Bob from respiratory, and Tom from perfusion. And it really required us fine-tuning things for us to smooth things out in that first week. And I think ever since it's been great. All right, any questions? Thank you. Guys, let me off the hook that easy? All right, very good. Well, I very much thank you guys for attending.